Hi, everyone. My name is Sarah Sieper, and I am the Knowledge Management and Strategic Communications Senior Associate on the Momentum Integrated Health Resilience Project funded by USAID. For the second episode of the series, we'll focus on health resilience in fragile settings to support improved family planning, reproductive health, and maternal newborn child health outcomes. Health resilience is defined as the ability of people, households, communities, systems, and countries to mitigate and adapt to shocks and stresses in a manner that reduces acute and chronic vulnerabilities and facilitates equitable health outcomes. Today, we have Isabel, Resilience Advisor for Momentum, to discuss some of the ways the project is working to strengthen health resilience. Welcome, Isabel. Can you go ahead and introduce yourself and provide a brief introduction on health resilience? Specifically about your background, your current work on Momentum, and how the project is working to implement health resilience.
Yes, thank you, Sarah. So I've joined the project from its inception in 2020, and I have had different roles within the project, but always around supporting and ensuring that we as a project adopt the health resilience approach to everything we do. Previous to this current role, I was a global resilience advisor at Goal Global, an international humanitarian NGO, which has a recognized expertise on resilience. I have about 25 years of experience working on disaster risk reduction, climate change adaptation. And when I joined the project early 2020, health was quite a mystery for me. But with the support of the whole project team, I started to learn more about family planning, reproductive health, maternal, newborn, and child health, community health, and it has been a remarkable experience for me.
Thanks so much, Isabel, and welcome again. I want you to first describe what health resilience is in a bit more detail. For example, how is health resilience connected to the broader concept of resilience?
Okay, so first to set up the scene, we need to understand that the concept of resilience in general, as we understand it now, is relatively recent. And there is not yet any completely agreed definition on the term. There are various definitions, and the most common concept of resilience, which is coming from the field of disaster risk reduction and accepted and used by most international NGOs and other international organizations working in the field of development, is understood as the ability of people, households, communities, countries, and systems to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces chronic vulnerability and facilitates inclusive growth. So in a few words, it means that it's the ability to thrive despite shocks and stresses. In the definition we are using, it is important to mention that the objectives of resilience is not for people, household, communities, etc., to go back to their previous state after a shock, but to continue improving their conditions and well-being after a shock and a stress. So now the concept of health resilience is even newer. So when we started the MIHR project in early 2020, we were challenged to adapt the resilience concept to the health sector. And then in 2021, USAID released their own definition of the term, which we are now currently using. And so the definition, as you mentioned in the introduction, is the ability of people, households, communities, systems, and countries to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces acute and chronic vulnerabilities and facilitates equitable health outcomes. Besides that, also a few years ago, very recently, the World Health Organization has also released its own definition, but this one is focusing on the health system. So it's the ability of a health system exposed to a shock to resist, absorb, accommodate, and recover from the effects of the shock in a timely and efficient manner, including through the preservation and restoration of its essential basic structures and functions through risk management. So in all those definitions, it's important to note that resilience is an ability It is not an outcome. And the outcome of resilience would be improved well-being. And in the specific case of health, it would be improved health outcomes, such as decreased morbidity and mortality, despite the occurrence of shocks and stresses. Finally, I would also like to stress that working on resilience and health resilience should be intentional. And we should be able to answer those 4 questions. Resilience for whom and of what? Resilience to what? Resilience how? And resilience to what end? In the context of health resilience, and particularly for MIHR, the resilience for whom and of what, it's of course our primarily for our target group. So the newborns, children, adolescents and young adults, first-time parents, pregnant and lactating women, as well as the actors within the local health system they depend on. For the second question, the resilience to what? So this depends on the country risk landscape. But generally, where we work, our target population are typically affected by different types of violence and conflicts, as well as environmental risks, such as flooding and disease outbreaks. So the third question, resilience, how? And so when the answer for this question is about describing our strategies to reduce chronic and acute vulnerabilities and increasing resilience capacities. And I'm sure we will discuss that more in details later in this interview. So finally, responding to the 4th questions, resilience to what end? So in the case of the MIHR project, what we want is our end goal is about to reduce morbidity and mortality among our main target groups.
Thank you so much for that. That was very helpful. So I know you talked a little bit at the end of that about what health resilience looks like in the context of MIHR. Since the project works specifically in fragile settings, can you talk a little bit about the relationship between fragility and health resilience?
Yes, so in the context where we work, like Sudan and DRC, where there are active armed conflicts in the area where we work, and for example, also in Niger, where there has been a recent political changes, or Mali and Burkina Faso facing regular terrorist attacks, even the health facility facing attacks. We are indeed working in a very challenging and fragile environment. So in our work, we often hear that fragile settings have the worst health indicators and weakest health systems, or we hear that we describe them circumstances where it is challenging to drive advances in or even maintain population health, with women and children among the most affected by those conditions. The terms fragility or fragile setting describe, in fact, a wide range of contexts characterized by shocks, stresses, and other factors that interact in various ways to affect the quality of and access to health services, including, in our case, the maternal, newborn, and child health, family planning, reproductive health. And as I mentioned, the countries where we work are considered fragile contexts. However, what fragility looks like in a given context, like the drivers, the impact and degree of fragility can differ. For example, while South Sudan, which is generally regarded as extremely fragile, is characterized by chronic fragility on multiple fronts: political, economic, security, environmental, social. Tanzania, on the other hand, is experiencing more moderate fragility and most prominently highlighted by environmental and economic factors. So in a few words, fragility and resilience could be the 2 sides of the same coin, and it's a bidirectional relationship. So understanding the fragility of the settings where we work and its impact on the health system and on the health of the population forms a critical part if you want to design programs that intentionally address the drivers and the symptoms of fragility and ultimately contribute to building resilience.
Thank you so much for sort of talking about and making the connection between fragility and resilience. As you stated earlier, the basis of health resilience is to help mitigate, adapt to, and recover from shocks and stresses that affect health and the health system. Can you talk about the three resilience capacities and how strengthening those ultimately helps to build or strengthen health resilience?
Yes, so one of the main aspects when we talk about resilience is about the abilities or the so-called capacities, as you said, to mitigate, adapt to, and recover from shocks and stresses. Those abilities can be characterized in different ways. For example, they are also called sources of resilience, and they could be about structure and systems, networks and relationships, skills, knowledge, behaviors, as well as resources and assets, which could be natural or physical or financial. And those sources of resilience can then also be organized into what we call the three main resilience capacities: absorptive, adaptive, and transformative capacity. So when we talk about absorptive capacity, we're talking about prevention and preparedness and the coping measures to avoid permanent negative impacts from shocks and stresses, and that maintain a certain health system stability. For example, if we do emergency preparedness plan at health facility level, and if we implement task shifting or task sharing to optimize the health workforce to meet priority needs during a crisis, those are examples for absorptive capacity. When we talk about adaptive capacity, we talk about the ability to make changes in response to long-term changes in the context. It's a capacity, in this case, of a health system to make adjustments while improving overall system performance. We are talking about small incremental adjustments to changes in the overall context, adjustments that will stay over time in the long term, not just put in place during a crisis. Like if it's only changes during a crisis, it's more about absorptive capacity. If those changes are made for the long term and are kept even after a crisis, it's more looking at adaptive capacity. So like leveraging new digital solutions, for example, that were put in place during COVID-19 for training, and then keeping them after for other things, that's continuing to improve the overall health system and strengthen the health system in itself. Or the promotion of self-care uptake for families to be able to manage diarrhea and fever during a crisis, but also on the longer term during normal times or calm times. Then now, when we are talking about transformative capacities, we are talking about changes in the overall enabling environment. We are talking about the ability to make fundamental change that addresses underlying vulnerabilities and contextual dynamics which impact system performance and the progress towards better health outcomes. So in this case, we can talk about major changes at structural level with new or updated budget, new policy, innovative policies, but it also encompasses changes within social norms, for example. So the three capacities are complementary and they are all important in their own ways. So absorptive capacity will ensure certain stability in the face of shocks. Adaptive capacity will allow for flexibility when needed, and transformative capacity will support a significant change further away from being impacted by initial shocks. But for example, even if a system is able to transform completely, there will always be new threats. And unfortunately, the new system will still need to develop its absorptive capacity, for example. So all capacities are important. But you can also, of course, as an actor like us, working on resilience and health resilience, you can decide to intentionally focus on strengthening one or two capacities only, maybe because of lack of resources or because of your own strategies, and depending on the context and the budget at hand that you have. But definitely strengthening one or all of those capacities will definitely increase the resilience of the people, actors, and system you are supporting.
Thank you so much for that response. So now I want to move more into a practical application of health resilience when it comes to global health programming. So can you talk us through the 4 major steps used in MIHR's interventions to help strengthen the resilience capacities that you just spoke about? Can you first start by naming the steps and then provide a high-level summary of sort of what's encompassed in each step?
Yes, so early on in the project in 2022, we developed a guidance that would support us in better integrating resilience into health project. So the first steps you're referring to are the main of stages of the program cycle. So assessment, planning, implementation, and monitoring, evaluation, and learning. So for the first one, it's about assessing the context where we work, and this includes, of course, the overall fragility context with the different shocks and stresses and their current and potential impact. We call them the risk scenarios. We also need to understand the underlying drivers of fragility or vulnerability and the existing capacities or sources of resilience that are in the context. So we are currently now, after 4 years, developing a new tool and testing it now called the Conflict Sensitivity Plus. And that's specifically for this first step. And it will help us assess conflict and fragility where we work. It's a health sensitive conceptual model of fragility. And we hope it will address a critical gap for health programming in fragile setting. It will support health actors to develop the contextual understanding to strengthen risk management and adaptability, identifies how fragility impacts health, inform program design and MEL, monitoring, evaluation, and learning, sets priorities in programming and resource allocation, and ensures that no unintended harm will come from that programming. Very important point. This tool will look at fragility factors by dimension. And by dimension, I mean political, security, economic, social, environmental, and also we will be looking at specifically health and health indicators of the population. Also on access and use of healthcare, and also on specific indicators around MNCH, maternal, newborn, and child health, family planning, and reproductive health, because of course we are a project working on these specific sectors. So this new tool will support us, hopefully, in addressing the drivers of fragility and risks as much as we can, and guide us towards developing activities and interventions that will increase health resilience of the population and of the health system. And that leads us to the second step that we are discussing, which is around planning. So this part, the second step around designing and planning the intervention and activities that would ensure so the reduction of current vulnerabilities and that we do no harm, and we build specific capacities for health resilience. So there are generic activities that we can plan for in these parts, like supporting preparedness activities at all levels. That's the most basic one. Supporting preparedness at health facilities, with community health workers, with community, like community health clubs, for example. And also, in parallel to that, of course, working with multi-hazards early warning and response system. Not just with disease surveillance. Of course, we'll be working on disease surveillance, but not just that. Other shocks are impacting very much our communities, and we need also to deal with them. We can plan and develop other activities, specifically, for example, on sexual and reproductive health. We have like the MISP, the Minimal Initial Service Package for sexual and reproductiveness in crisis, that we can also develop as an activity and integrate within our own activities. So the third step then is the implementation of all those activities within our project. And finally, the last step is on monitoring, evaluation, and learning. And of course, those last two steps, the implementation and the monitoring and evaluation and learning, of course, needs to occur concurrently to really ensure adaptive management and learning while doing, because we need to build new evidence on health resilience.
Thank you for talking about sort of the more practical and sort of what health resilience and health resilience strengthening looks like from a project perspective. I want to end the interview with this question. So for global health professionals out there or those working in adjacent fields that are interested in incorporating health resilience into their work, where should they start? You know, websites to visit, resources to review, trainings to participate in, and things of that nature.
Yes, so of course I can follow MIHR, the website, the Momentum website, or on LinkedIn. Very soon we will be releasing some guidance this year on how to support, for example, frontline health facilities in developing emergency preparedness and response plan. Next year as well, we will be releasing the overall health resilience guidance. That will include all the different aspects I've been talking about today. Besides the Momentum Integrated Health Resilience, I could mention, for example, USAID. They have developed extensive resources on resilience that can be applied to health, including guides on resilience programming and integrating resilience across different sectors. The WHO as well has recently released a very good health resilience toolkit, but it's mainly focused on health system that you
Thank
could
you so much
attend.
for sharing those resources. I feel like those listening will find those helpful. And also thank you again for sharing your insight and your knowledge on how strengthening health resilience can really impact health and health outcomes in a positive way.
Thank you.